7-1 in medic 6. You're seeing a 74-year-old male, shortness of breath.
Do you have much homework tonight? Hey, Sue.
Hey, David.
It's my daughter, Catherine.
Hi,
This is
hon.
Sue.
Hi. Nice to meet you. Y'all just getting back from lunch?
Yeah,
Where'd y'all go?
we ate Mongolian food. Are you okay? Your neck is looking kind of rough.
I don't feel too good.
You're not looking too good.
Maybe you need to call your mom and get her.
The immune system is one of the most complex systems in our body. To protect us, it continuously monitors for antigens, foreign substances like microorganisms or non-living substances that have entered our body, and activates a counterattack. Depending on the antigen, the immune response can be mild or severe, localized or systemic, immediate or delayed. When it is severe, it can lead to anaphylaxis.
We're gonna call somebody for some help here.
I don't feel so good.
Anaphylaxis comes to us from a Greek word of anaphylaxis, ana meaning against and phylaxis meaning protection. So anaphylaxis means opposite or against protection. And really it's one of the scariest things that an EMS provider would ever see. It's a massive allergic reaction that is an extreme life-threatening condition to the patient who's suffering from it. Very physiologically complex. It has lots of things that potentials to go wrong. The good news is most allergic reactions are not anaphylactic reactions. And an anaphylactic reaction is an allergic reaction that has actually magnified itself to a point where it becomes a threat to the patient's life.
Why don't you sit back for a minute?
Antigens enter the body by inhalation, ingestion, injection, and/or absorption. The most common organ systems that initiate an anaphylactic response include cutaneous, respiratory, cardiovascular, and gastrointestinal systems.
Your food, but you're not allergic to anything, are you?
More than one organ system should be involved for the reaction to be considered anaphylaxis. This is a true medical emergency because of its speed, severity, and ability to kill.
So with the fire department, what seems to be the problem? Are you having trouble breathing? Okay. Do you have any medical history we need to know about? High blood pressure, diabetes, anything like that?
I was allergic to peanuts as a child.
Okay, is it possible you had any peanuts today?
No.
Okay, when was the last time you ate?
When the immune system releases antibodies, immunoglobulin E, or IgE, the antibodies stick to the mast cells and basophils, causing the release of mediators, such as histamine, to fight off the antigens.
But histamine is the main offender. And what occurs, if you have hay fever, you can have itchy eyes, runny nose, watery eyes maybe. And that's an effect of histamine as well. If we talk about anaphylaxis, that's histamine times 1,000. And what that does is creates this massive effect on the body, and it affects about 4 systems in the worst way. Respiratory system, bronchioles will begin to shrink. You'll have bronchoconstriction with some swelling in the mucous membranes, which causes wheezes that you'll see in the patient. You'll also see some GI effects. The motility of the GI tract increases to a point where a person will become nauseated, maybe vomit and have diarrhea. Central nervous system can be affected with altered mentation, and the cardiovascular system is also at risk, and that is because the histamine actually vasodilates the peripheral tissues, and then all of your blood, or most of it, can move out into the periphery. When that happens, you get shock, and shock is what eventually will kill you, along with that dangerous respiratory component of not being able to breathe. So you're suffering from hypoxia as well as hypoperfusion when you have an anaphylactic reaction.
I noticed this rash. How long have you had this here?
Just came.
After you ate?
Yeah.
Okay.
In the respiratory system, anaphylaxis may cause dyspnea, which can be accompanied by sneezing, coughing, upper airway stridor, laryngeal edema, airway obstruction, and bronchospasm. The cardiovascular system may experience vasodilation, decreased blood pressure, and tachycardia. Anaphylaxis may affect the nervous system, causing headaches, seizure, or coma. Cutaneous reactions are very common, including itching, hives, blotches, flushing, or swelling.
There's basically 4 types of hypersensitivity reactions: type 1, type 2, type 3, and type 4. Types 2, 3, and 4 are usually localized reactions, something like poison ivy, or maybe allergic to a new laundry soap that you'd have. And they're a nuisance, but they cause some itching and swelling, maybe a little bit. The bad ones that we have to look out for are type 1 hypersensitivity reactions. Those are the ones where the immunoglobulin E plays a role, which is the one that causes anaphylaxis. And so with that becomes this overwhelming life-threatening condition because of the degree of hypersensitivity.
Anyone can have an anaphylactic reaction even if they have never had a reaction to a particular substance before. The most common causes of anaphylactic reactions are drugs, like antibiotics such as penicillin, foods like peanuts, shellfish, or eggs, insect stings from bees, wasps, or fire ants, and allergies to latex.
So if somebody's stung by a bee or they had a shot of penicillin, the chance, if they are allergic to that, the chance of the reaction happening quicker is obvious. And those are the 2 biggest offenders: penicillin injection and Hymenoptera to bee-type stings.
All right, so we're going to give you a nebulizer treatment. What that is going to help open up your lungs so you can breathe a little easier. The medication my partner's putting in there is called albuterol. Are you allergic to albuterol? Okay, have you ever had it before? Okay. Go ahead and give him 2.5 milligrams of albuterol. Is that it?
So bottom line with that is crucial to ask about patient allergies before you administer any kind of medication in the field. And it's good to ask several times just to make sure. And if a patient says, yes, I'm allergic, ask, how were you allergic? Did you have a full-blown reaction? Did you get a rash? Did you have shortness of breath, or those kinds of things?
So what you're going to have to do is you're going to put this mask on your face. We're going to switch out masks, and I want to have you taking all the medication. So nice, easy, deep breaths.
Emergency treatment should be focused on supporting vital functions while eliminating the 3 primary factors that are producing the signs, symptoms, and pathophysiologic conditions: the increased vascular permeability, vasodilation, and bronchoconstriction.
How's it feeling? Is that better? Shake your head yes or no. Okay.
ABCs are absolutely vital with anaphylaxis because you have an airway, a breathing, and a circulation problem. The airway may be swelling from the allergic reaction. The breathing's impeded because you have all this fluid coming into the alveoli, and you have bronchoconstriction occurring, so you can't get air down into the lungs to pass into the bloodstream. After you've suctioned and made sure the airway's clear, you need to have, if the patient's breathing has a good tidal volume, you can give them 100% via non-rebreather. If they're not, you may need to supplement their oxygen delivery with a bag valve mask with their oxygen reservoir at 100%, or possibly intubate these folks. Circulation-wise, you have all of this fluid shifting out into the third space, and you need to get some fluid back into the circulating volume, and that's best done with IV fluid and sometimes drugs with like a vasopressor.
Just because of the rash and your hard time breathing, I'm thinking you're having an allergic reaction to something. So in case you start swelling up, I'm going to have you take off your ring, okay?
Act fast with the basics. Assess and maintain your patient's airway. If your patient is experiencing difficulty breathing, consider albuterol per local protocols. Assess circulation. Note the skin color, capillary refill time, and signs of mottling. Provide supplemental oxygen. Treat for shock. Remove any rings or jewelry in case of swelling. If your patient is unconscious, look for medic alert tags or other clues to possible allergic reactions.
Something that's crucial to remember is to watch the patient's respirations. And remember that usually the more severe the reaction, the quicker it's going to occur. If the patient's respirations are changing, they're developing wheezes, shortness of breath, their voice is hoarse, you need to watch that person very closely and start treatments immediately. Get high flow oxygen on them and do the other things that we said before. Don't wait for the blood pressure to drop to treat for shock. Anticipate it. This is a very dangerous situation, and think ahead. If you're a BLS unit and you're going to a known person who's allergic to bee stings that has been stung, get a paramedic unit en route if you have that availability. If not, think about the EpiPen and if the patient may have that. and never minimize the potential of what could occur. Again, a lot of people learn about this in class, but then when they see a person who's been stung or had a food allergy and went into full-blown anaphylaxis, it's a scary thing. And sometimes these people don't survive. And so you gain a very healthy respect right away for the magnitude of what you're dealing with when it comes to that. So.
Treating someone with anaphylaxis can be difficult because it's not always clear what is wrong with the patient. That's why rapid recognition through the history and physical signs of the patient is important to survival.
This is Mr. Darcy. He appears to be having some kind of anaphylactic reaction. It came on after he ate lunch. Right. He's having wheezing in all 4 lobes, got the rash around his neck. He does have allergies to peanuts. That's the only medical history that he has.
Did you eat any peanuts today, sir? No?
Okay. We've given him albuterol. Okay. Already administered that already. All right. An rebreather and just taking his vitals. He's got 140 over 90.
40 over 90. Fire's vitals 140 over 90.
130 on the heart rate.
BLS should take a great history and know exactly what's going on so you can recognize the problem to begin with. Then give some oxygen right away. If the patient's airway is not patent, you need to make it patent. When you do that, you need to be careful that you don't use airway adjuncts that are too large or whatever, because you can have a lot of swelling in the patient's airway. And if you're in there doing things that you shouldn't be, it can become a lot worse. Suctioning, because the GI tract's in overdrive, people can vomit a lot. You need to keep the airway clear or else the oxygen that you're trying to put in won't get there. So very, very important to do that as well. And then circulation-wise, very crucial to keep these patients calm. You don't want them running around because that just increases the circulation of the histamine and the other chemicals that are released. And so you want to keep them down, and if they're cover them if they're cold to keep them out of shock and try and prevent that. And most importantly, get them to a place, if you don't have epinephrine, where they have epinephrine. So you might call Advanced Life Support Rendezvous, or perhaps ask if the patient has an EpiPen.
Sir, my name's Kevin. I'm paramedic with Austin EMS. What's your name? David. Okay, we're going to do quite a few things to you here, okay? So I'll probably give you some medication in just a minute here to make you feel better. First, I'm going to listen to your lungs again. Rudy, can you go ahead and get them on the pulse ox? Eric, can you go ahead and set up an IV for me, please, with a big bag? Sure, you got the pulse ox here? Right. Grab this, and then go ahead and get the inside on them. Sir, can I see your finger here?
If your patient is carrying a preloaded epinephrine auto-injector, you may assist him in administering it. Epinephrine constricts and reduces leakage from the blood vessels, which increase the patient blood pressure and pulse rate. It also dilates the bronchioles, which eases the patient's breathing. It is a fast-acting drug, taking effect in seconds, but only lasting 10 to 20 minutes. Indications for use are respiratory distress with wheezing, stridor, hypotension, or shock.
Another thing to do is to watch for vital sign trending. You need to check vitals continuously, and if these people are getting worse, again, expect the worst. So watch their level of consciousness. Folks who get hypoxic sometimes get very anxious. They can have all kinds of different behaviors. They're very scared is a very common one. If they've been through a bee sting or an allergy before that was life-threatening, of course they're going to be scared, and so you need to appreciate that. Also give a lot of psychological support to these folks, because they're going to need it. Have all your ducks in a row, be prepared with your treatments, and ready to go and act quickly in this to save the patient's life.
Sir, are you starting to feel better? A little bit. Is the dizziness still there?
A little bit.
But it's a little better now? What about the nausea? Has it gone away?
Not totally, but it's better.
Okay. I'm going to listen to your lungs one more time, okay?
ALS care includes continuing to assess and manage the airway using a BVM if ventilatory assistance is needed, continuously reassess vitals, apply a pulse oximeter and ECG monitor, and start an IV of Ringer's lactate or normal saline. Your next step should be to determine the severity of the anaphylactic reaction. Medication and route of administration will depend on how severe the reaction is.
If you're a paramedic, you can give epinephrine. We usually don't give epinephrine for a mild reaction, but a moderate, bordering on severe, we can. And that would be an IM route or a sub-Q route of 1 to 1,000 epi. And we give that based on our protocol, obviously. And then for very severe people in anaphylaxis, we might actually give 1 to 10,000 epi IV. Epinephrine is the best drug, hands down, for anaphylaxis. It's going to fight off all those bad things that the body can't do on its own. The body does try by creating some epinephrine, but not enough. So when we add more, it's much, much better. Other things we can give are antihistamines, like a Benadryl or diphenhydramine. And with that, that's an antihistamine that will start to counteract those effects of those bad histamines that are there. There are too many of. Some folks will give a corticosteroid, like Solumedrol perhaps, to try to stop some of the inflammation that occurs with that.
50 milligrams of Benadryl's in. Circulate a little bit here.
You also need to think about supporting the circulation with IV fluid. Because those people are third spacing or moving all of their fluid out into their periphery because of the vasodilation from the histamine, they need fluid put back into their intravascular area. When that occurs, the fluid will start to take effect and you'll start to perfuse the vital organs again that what you had before you lost out to the tissues. So IV fluid's important as well.
Run an IV of Ringer's lactate or normal saline wide open or according to your local protocols. Do not delay transport for an extended period of time while you try to get an IV. If one can't be placed right away, do it in transport.
How about the nausea? It's still hard for you to breathe? Okay. I'm gonna listen to your lungs.
One of the other ALS procedures that can be done is the administration of a beta-2 agonist, and that's basically a bronchodilator drug. Because the bronchoconstriction that's occurring from the release of histamine is there, the beta-2 might be able to give you an effective bronchodilation and thereby just give you a better airflow through your bronchioles so that you can get some oxygen to the lungs and subsequently out into the blood, into the tissues. So something like an albuterol or whatever's carried on the ambulance could be an adjunctive method to use as far as pharmacology goes, but epinephrine by far, and with obviously assuming oxygen has already been started, are the two mainstays for the treatment of anaphylaxis.
Anaphylaxis is a true life-threatening emergency. Prompt recognition, response, and aggressive management of the basics give your patient the best chance at survival.
There are some other ideas too. Not wait too long to treat these patients. If their blood pressure is dropping, you have to get involved. But even before that, respiratory distress can be your biggest signal. If these people are having trouble breathing, you know that this is progressing quickly. And if you know that they were stung 10 minutes ago and gotten worse ever since, you can expect the worst. And so you should expect the worst and hope for the best. With that, watch the respirations, and then also don't wait for the blood pressure to fall to treat for shock. That's not acceptable treatment in that regard. Some pearls of wisdom, I would say, when you're treating a patient with anaphylaxis is number one, to be prepared for this. It's not something that you're going to see all the time, but when you do, you need to know what to do and when to do it, and you need to do it right now. It's just vital because this patient, as we described, is not getting oxygenated, they can't breathe, they have all these things going wrong with their body at one time, and you have to be ready.
So I'm going to listen to your lungs one more time.